Thank you very much, Jennifer, and good morning, ladies and gentlemen. Thank you for coming out on a morning when I think most of us would much rather have stayed in bed. But it's a really, really important issue, as you say, Jennifer. Probably the single thing that's closest to my heart as Health Secretary. And I just wanted to start with a word of context, because the NHS gets a lot of bashing in the papers, and there's a lot of stories about pressures in A&E departments. My own view is actually that it's holding up extremely well under huge pressure. By the time of the election, we'll have 1 million more over 65s in the country than we had at the last election. And at a time when the NHS budget hasn't gone up by very much, to have sustained the performance it's sustaining, including doing around 1 million more operations every year, is really impressive. But I want to try and prove to you this morning that the biggest thing that's happening in the NHS is actually something that the newspapers aren't talking about at all. There is a quiet revolution going on in terms of attitudes to safety, which history will judge, I think, to be the moment where the NHS resolved and in fact became the first healthcare system in the world to develop airline, oil industry, nuclear industry levels of safety. And I think the NHS could be the start of a global revolution in healthcare, where we completely transform the approach that healthcare has taken to safety issues, where I think it's been behind the curve for many, many reasons, probably principally because people are always going to die in hospitals, and so that's conditioned us all to have a different view about mortality in healthcare to in those other industries. But I think if you look at what's happening, it is very exciting, and I just want to talk to you about some of the things I think are happening, but also some of the things that still need to happen. And I'm delighted that you're having this conference, Jennifer, and I want to thank you for your contribution to that change, because one of the key things that is driving that change is the new inspection regime that the CQC are doing, which puts a big, big emphasis on safety. And obviously change has to come from inside, not from outside, but it is a very big help if the independent inspection system against which your hospital is being judged is putting such a high emphasis on safety, and you helped a lot with that. I'm also delighted that you're going to be hearing later from someone who knows far more than I do about these issues, Martin Bromley, who can give you a much more chapter and verse about the parallels with the airline industry, which is something that I also want to draw on. But as with so many of these profound changes, very often they start with a tragedy. And the tragedy is what inspires action and change. And in our case, as we all know, the tragedy was mid-staffs. And the reason I think that this has become such a something that I'm so passionate about is because the Francis report into mid-staffs was the first thing I had to deal with as Health Secretary. And actually the first, I was Culture Secretary responsible for the Olympics, and then I planned a holiday at the end of the Olympics because I was pretty knackered, and a week before the end of the Paralympics, was promoted to Health Secretary. And I needed to go on the holiday because I was just so exhausted, but I took away a huge amount of reading, and about the first thing I read was the first Francis report into what happened at mid-staffs, and I was absolutely appalled. In fact, I was just stunned. And this had actually been in the public domain. I'd read about it in the newspapers, but I hadn't actually read the report. And we all know what happened there, and I don't need to go through that now, but you know, I think the interesting thing was that when we started looking at what happened at mid-staffs, we can take it as a given that no one wants to have hospitals where dementia patients don't get fed, where people get left in soiled sheets, and so on. And I'm actually very confident that we are building an NHS where that kind of thing happens less and less. And in fact, there is so much determination by brilliant NHS frontline staff that I'm as confident as I can be that we will basically stop that kind of thing happening. And if it does happen, it certainly won't take us 4 years to find out about it. But the question here, and this is, I think, is the challenge, which I think is engaging people in this room, and it's why you're here this morning. The question is, what is the normality? What is the non-mid-staff's normality that we want the NHS to get back to? Of course, we don't want those horrific things to happen. But then and I think most of the time it's a massive disadvantage not being a doctor when you're health secretary, but just occasionally it's quite helpful not to be a doctor. And people started telling me one or two things that were quote unquote normal in the health system. The fact that, for example, once a fortnight we put the wrong prosthetic onto someone's body. The fact that once a week we operate on the wrong part of someone's body. The fact that twice a week we leave a foreign object in someone's body. The fact that every year more than 40 people die in the NHS because they're given the wrong medicines. The fact that every month we have 1,000 avoidable deaths in the NHS. The fact that last year in one NHS hospital we amputated the wrong toe of someone. In another highly respected teaching hospital we removed someone's fallopian tube instead of their appendix. And that is the non-mid-staff's normality. And I think it's really important to say this is not just the NHS. This is normal in healthcare systems across the world. Someone very senior in the NHS said to me in my first few months as health secretary that it's completely normal in healthcare systems across the world that 10% of patients get harmed in the course of their healthcare. And if you talk to people in America, America I think is the only other country in the world that's really interested in trying to engage with this agenda seriously. If you talk to people in America, they will tell you that they have the same kind of level of avoidable death. And then if you look at the statistics for France or Germany, you find that it's, you know, plus or minus a percentage or two. And, you know, the question we have to ask ourselves is, should we be accepting this as normal in healthcare, or should we be changing it? And the NHS turned heads across the world in 1948 when we said we wanted to be the first country in the world where it didn't matter if you were rich or poor, young or old, city or country, you were going to have access to good quality healthcare. We wanted to be the kind of country where everyone can access good healthcare. I want us to be the first country in the world that says we want to eliminate avoidable harm, eliminate avoidable death. We won't get there immediately, but we can be the people that blaze a trail. And at the heart of that is culture change. And how you change culture is an incredibly difficult and complex thing, and you're going to hear some brilliant thoughts later on today about that. But I just want to talk about the airline industry for a moment, because I'm a part-time football referee. Anyone who knows about football knows that people who can't play ref, and I'm definitely in that category. And one of the people that I referee with is an EasyJet pilot. And as I was going through the wrestling with this issue, I used to talk to him about the safety culture in airlines. And you're going to hear from an airline pilot who's making it his life's work to change this, and he knows far more than me about this. But as I see it, 30 years ago, if I had been flying a plane across the Atlantic and I made a mistake, assuming I'm still alive after that mistake, basically I only had one person sitting next to me who saw it, and I just really needed to look over to him, probably was a him in those days, and say, that never happened, did it? And he would give me a wink, and we'd cover each other's backsides, and the flight would carry on. Now, 30 years ago, the airline industry realised that if they didn't change that culture into a learning culture where every single mistake was logged, was thought about, was analysed, and people then thought, how could it be avoided in the future? They weren't going to have a business, because about 2,000 people were dying every year in crashes, and that of course, is one of the most scary things possible for the customers of airlines. And so they embarked on this program to change the culture of pilots. And in that process, I mean, I remember a friend of mine's father was a British Airways pilot, and one of the stories he told me about the airline culture in those days was that they used to play tricks on the passengers on April Fool's Day. And sometimes the pilot would arrive not wearing uniform and would sit in one of the seats next to the other passengers, and the steward would walk up and down the aisle saying, "Where's the pilot? Where's the pilot?" And then the plainclothes, non-uniformed pilot would stand up and say, "I reckon I can fly this baby," and would stroll up, and then off they would go. And probably things were a bit more fun in those days than they are now. But the airline industry has learnt that you have to make it easy for pilots to speak up when there is a problem. And Martin will tell you, but my EasyJet pilot friend told me that he thought there were 5 different ways that he could raise a safety concern to his union, to his airline, to the CAA, to an anonymous charity that's run by the CAA. And he could complain anonymously, he could complain in his own name. The one thing that was common with all these methods of complaint was that there was always an acknowledgement, and that it was absolutely drummed into him in his training that the safest thing for him to do in terms of his own personal career is to report an incident. The most dangerous thing is not to report an incident, and as long as it's not gross negligence, essentially you're safe if you report it. And the result of that is that over the last 30 years, the average fatality in the airline industry has gone from 2,000 a year to less than 500 a year. And that is in a period where airline travel has increased by 9 times. So that is an extraordinary safety record in that industry. And what do we learn from that, from healthcare? Well, there are some really interesting examples as to where this has been embraced in healthcare. I'll give you one from the US and one from the UK. So the US, a hospital that Jennifer will know well, Virginia Mason in Seattle, probably the safest hospital in the world. They killed a lady called Mary McClinton in 2004 by injecting antiseptic fluid into her brain. And that was their tragedy, their mid-staff's moment, and in a way that was the moment. But the chief executive of the hospital, an incredibly inspiring man called Gary Kaplan, he decided that he was going to email, this lady, Mary McClinton, suffered a death that basically lasted 2 weeks. And while she was still alive, he sent an email around to all the staff in the hospital explaining exactly what had happened. The problem was that the fluid that the antiseptic was in was the same colour and put in the same place as the fluid that should have been injected into her brain, and so the surgeon just made a mistake. Gary knew this would get out to the local press and the hospital would get a huge amount of criticism, massive reputational damage to the hospital. That happened. And then they started on their journey, which was essentially a journey about making it easy for staff to speak out and engage in the kind of process changes that eliminate patient harm and patient danger. And he went through this huge process. I mean, they, when I went to see them earlier this year, they were celebrating the fact that for the first time in 1 month, this is a small 300-bed hospital, in 1 month they had had 800 patients, 800 what they call patient safety alerts, where doctors and nurses have raised a concern about a safety procedure, and in 1 month they'd had 800. I think you would struggle to find an NHS hospital where you've had 800 concerns raised in a year, let alone a month. And Gary can show you a graph where over the last 10 years the number of patient safety alerts has gone right up, and at the same time the number of litigation claims against the hospital has gone right down. So let no one say that safety is expensive, safe care costs less, and that's another really important message to get across in the current environment. But after they'd been on this journey, or a couple of years after they'd started this journey, they discovered that at another hospital in Seattle, the same thing had happened with another patient 2 years early at a neighbouring hospital. But that hospital had covered it up. And if they hadn't covered that up at that hospital, Mary McClinton might be alive today. And that is the point of having a learning culture. It is that you're not looking to blame people. Everyone makes mistakes, but you're trying to create an environment where people can speak out, where you have an open and honest reporting culture, where you encourage people to learn from their mistakes, and you tap into that desire and passion in every single doctor and nurse to do the best possible job for patients. I mean, the great thing about this agenda is we are not going against the grain of what frontline professionals want to do. We are going with the grain of what they want to do, but we've got to create the system that supports them to do that. So we have a great example in the UK. Professor Sir Bruce Keogh is the NHS England Medical Director. He's a former cardiac surgeon. And in 2003, he and another cardiac surgeon called Ben Bridgewater decided to try to persuade their cardiac surgeon colleagues to publish their mortality rates, their survival rates from cardiac surgery. Huge opposition. People said, if you do this, we won't want to do the riskier operations. So they put in a risk adjustment system, a lot of negotiation. Eventually, they did persuade their colleagues to do it. And what they started doing was contacting surgeons who were outliers, who were having higher than average death rates from their cardiac surgery. And those surgeons, I remember saying to Ben, is this a question of being steady with the scalpel or something? He said, no, it wasn't that at all. It was basically about procedures. The people who were having the higher mortality rates were the people who weren't following the procedures, and therefore they were allowing mistakes to creep into what happened. And so the people who were the outliers generally started following those procedures. Sometimes they stopped doing some types of operation. Sometimes they stopped practicing altogether, but that was very, very rare. And what happened was that there was a dramatic improvement in mortality rates to make our mortality rates for heart surgery some of the best in Europe. And we are now embracing that approach across the surgery, all surgery, and we want to take it outside surgery as well. And that's why last month on the new MyNHS website, we are publishing surgery outcome data, first country in the world to do it across the whole healthcare economy, to try and create that learning culture, that improving culture. So there are some really exciting things happening here, and I think in the last couple of years there's been some fantastic progress. We've got the new inspection regime with Professor Sir Mike Richards, who is absolutely brilliant and putting a big emphasis on safety. I think people who run hospitals are ambitious people, and they need to know that our definition of success for a hospital is not just A&E targets, important though they are, patient safety, compassionate care, all these things matter as well, and Mike has really changed the dial with respect to that. We have Sir David Dalton's Sign Up to Safety campaign. Salford Royal is probably the safest hospital in the UK. He has now got 160 NHS organisations to sign up to halving avoidable harm and halving avoidable death within 3 years by changes they make within their organisation, and that is a fantastic step forward in terms of creating that learning culture. We've got the safety thermometer that's been going on since 2012, 5.3 million people now, patients have supplied their data on that. We've got hospitals like St Thomas's starting the concept of patients arriving at the hospital seeing a safety video, just like you see a safety video when you start a journey on a plane, because we need patients to engage in the safety agenda as well. We've got the announcement that we're making today about the 5,000 safety fellows, a joint initiative between NHS England and the Health Foundation. I'm most grateful to you, Jennifer, for your support for that announcement. 5,000 safety fellows, patient safety fellows across the NHS, who will be ambassadors and champions for this agenda. There's more to do. I mean, we've got, I think, to do much better on sepsis, which is a particular area where we're still losing too many people every year. And that's not just in hospitals, that's in primary care as well. We still have a long, long way to go to remove the bullying culture that still exists in parts of the NHS, that makes it difficult for people to speak out. We've got to untangle employment disputes from whistleblowing, and the two have got muddled up. And Robert Francis is doing a follow-up inquiry to help us understand that. That will be really important. And, you know, getting that cultural change isn't going to happen overnight. But, you know, what I can say is that sometimes in politics you feel like you're pushing water uphill. Sometimes you feel like you're going through an open door. And there is so much enthusiasm in the NHS around this agenda, and it's enthusiasm that comes right from the front line. People are absolutely passionate about doing this, and I think the responsibility on us as system leaders is to create a system that allows them to do what they want to do in this respect. It won't be easy at all, but I'm absolutely confident we can get there. Thank you very much indeed.
We've got a few minutes for questions. While you might be thinking of yours, perhaps I can sneak one in. Francis, Keogh, Berwick, a lot of recommendations, a morass and a dizzying amount of activity going on, actually. I'm thinking about your role, and just assuming now, apart from the small matter of the general election, that you are in your position for the next 5 years. Of all the massive things, of all the massive recommendations, where are the 2 or 3 areas that you think, in your role, you can really make a difference as Secretary of State, given that you're a long way from this clinical culture that you quite rightly describe?
Well, I think the most important thing for a health secretary is consistency. Because, you know, the NHS is so huge, 5th largest organisation in the world. Bill Clinton once said that politics is like working in a graveyard. There are lots of people underneath you, but they're not necessarily listening. And I think, you know, you have to be really alive to the fact that it's just not always the case that just by pulling a lever in Richmond House in Whitehall, something is going to change in a hospital ward in Macclesfield. It doesn't work like that, and that's why I think you have to be very consistent over a long period of time. And I've always said the 2 things that I think I want to focus on in my time as Health Secretary are developing a culture of safe, compassionate care and transforming out-of-hospital care, which is, I think, what we need to do with the ageing population, have better care closer to home, more integrated, joined-up care outside hospitals. And so I stick with those 2 priorities. And like you, I don't know what's going to happen in the general election, but that's why I said that you know, if my party does win, I would like to stay in this post if the Prime Minister will have me, because I would like to see this through, and I do think it takes a while.
Okay. Thank you. Could you just say who you are and use the mic?
Thank you. Vinda Walker from Birmingham Children's Hospital. Secretary of State, well, thank you for your talk, which I enjoyed very much. But one of the things that concerns me is the public understanding of safety. And Midstaff's, I think, tells us a lot about how much the public understand, where after what happened there, you had a new chief executive saying that she couldn't run her emergency department safely with the sort of staff and numbers that they were able to attract. And then that then led to a public campaign to keep the emergency department open. Now, I'm no great fan of closing down small hospitals, so In fact, I think the public do have a right to have local healthcare provision. But this business about trying to organise healthcare in a way that it is safe, but in a way that we take the public with them, I wondered what your views about that were.
Well, I think first of all, congratulations to Birmingham Children's Hospital, because you've done a lot of fantastic work on safety, and I really much enjoyed my speech there when I looked at this. I tried to look squarely at this issue of does it cost more or less to do safe care, and I tried to look at some of the costs, which I think we concluded are between about £1 and £2.5 billion a year is the cost of poor or unsafe care inside the NHS. Litigation alone is £1.3 billion a year. I think that one of the problems that we've had in the past is when you've tried to organise healthcare more efficiently, the public have just suspected that there's a financial motive behind it, and that therefore what they need to do is to shout as loudly as possible to try and make sure that the care they get is as close as possible to their home. And I think that debate has improved a lot when it's been led by doctors rather than by NHS managers and politicians. And we're not there yet, but if you look at the big improvements in stroke survival rates in London since we moved to having hyperacute stroke units in 8 hospitals in London rather than in 32, dealing with strokes in 32 different hospitals. That's been very successful. We can now look at the improvement in mortality rates, and we can say to the public, yes, it does mean that if you have a stroke, you won't necessarily go to the nearest hospital to your home, but you will go to somewhere where you'll be seen by a stroke consultant who's probably seeing between 6 and 8 people a day with strokes, rather than what would have happened before, where they were just seeing 1 or 2 people a day. And therefore, he or she will be better at making the right judgments, and you will have a better chance of surviving. And so I hope that debate is beginning to move on.
Okay. I have the lady there with the glasses.
My name is Josephine Ocklew, and I'm a patient representative and someone affected by a serious untoward incident as a result of the death of my daughter. I was trying to think about how to construct my question, because it's been quite difficult to ask those questions in a room like this over the last few years, because often when you've been harmed by a patient safety incident and you've had a poor experience and you want to ask some of the difficult questions, you don't always get a very good reaction. So I want to sort of ask a question on behalf of other people like me who rarely get into the room like this. And it's stuff around being doubly harmed when you've been affected by a patient safety incident and then been affected by the cover-up culture like myself, spending years and years and years going round and round in circles trying to get the complaint system and the regulators to deal with your issues. So Jeremy, I'd like to make a plea to you that that's a really important thing that we want you to address from a harmed patient perspective, and I want you to address, because I've spent years trying to get my daughter's death independently investigated.
Well, thank you for asking the question, and look, I'll give you the sort of the good news and bad news if I can on that. I mean, one of the first people that I met when I was Health Secretary was Scott Morris, whose son Sam died from sepsis in Devon. And he described how he was told by the hospital it was unavoidable, and he grieved the loss of his 3-year-old son for 6 months without questioning that. And then it was only how, when he started to piece together what had happened, he realised that it wasn't unavoidable, and that there were a series of mistakes from primary care to hospital, which had they not happened, could have meant that his son was still alive. And he described how the NHS just totally closed ranks. It was not interested in engaging with him. Everyone backed each other up. He didn't get an apology from anyone. The only person who apologised actually was his GP. And his wife said to me that they still actually use that GP. She said, it's actually very difficult for me to be in a room with that GP, but I still use that GP. And I thought that really said something about how patients think about this, because they just want to know that the system has learned from their mistakes and isn't covering it up. They know that the tragedy you can't turn the clock back on those tragedies, but they want to know that the system is acknowledging the mistake and learning from it, not sweeping it under the carpet. And you're absolutely right, that is the culture that we had. We had a culture in the NHS where no one was allowed to say anything other than good news, and the result was that these tragedies weren't properly investigated. People thought it would end their careers if they owned up to something going wrong, exactly the issues that we've had in other industries. And there's nothing I care more about than changing that culture. I think the honest truth is, though, that it doesn't get changed overnight. It takes time to do that. And I think that, I was having a conversation earlier, I think that it is now understood, this change, at the highest levels of the NHS. I think even at chief executive and board level of hospital, I think they are taking these issues a lot more seriously. But it takes time for this to filter down, and there's still too many tragedies. I still write letters to patients and their families every day about tragedies that have happened, and so I don't want to pretend that we've done anything other than start on that journey.
Okay. Yep. So this lady here.
Hi, Jane Reid. You mentioned a lot about culture, and we would all recognise that, and Martin's going to talk about human factors later, and you talked about parallels with safety critical industries. As Secretary of State, I wonder what your view is about how we maximise the purchasing power of the NHS and we use design much more effectively. The example that you gave about the patient that had the drug, the antiseptic injected in her head, it was because they were non-labelled syringes. That same incident happened in this country in January, affecting a teenage girl. She didn't die, but she's just received a significant payout, litigation payout. We need to be much more creative about designing out error so it's easier for people to do the right thing. And if you think about what we spend in the NHS, there needs to be, at the very strategic level, a reasonable conversation about how we use our purchasing power more effectively.
I totally agree. And I think it's really interesting. I mean, so we get into this question about, how do I try and make that change happen sitting at the top of an organisation of 1.3 million people? And what really strikes you when you go to hospitals that get this, like Salford Royal, is that doctors and nurses on the front line are engaging with this issue, and they're thinking it through, and they're thinking up their own solutions as to how to make things better in their ward, in their theatre. And it's not about waiting for the Department of Health to come up with a blueprint that everyone follows, because that just takes too long, and frankly there are too many blueprints that we publish and people can't manage to implement all of them, so they have to make choices, and so it has to come from inside. And then once you have success, in reducing hospital-acquired bed sores, for example, then it's about diffusing good practice throughout the NHS, and that's where I think the inspection regime that Jennifer helped me design has been so important, because if your record as a hospital is rated inadequate, the first thing and the easiest thing to do is to go and look at a hospital where the safety record is good or outstanding and to copy it. And this new Ofsted-style inspection regime is designed to encourage people to actually go and look at what's happening in their neighbouring hospitals. So I was really thrilled. My local hospital is the Royal Surrey in Guildford, and the chief executive invited me to come and look at his wards. And he said, Jeremy, I just want you to see these wards because they're actually not great. And I obviously know these wards very well. I've had relatives in them and I've visited people and years and years and years. And he said, they're not great. And I want you to come back in 6 months' time, because we're just sending a team of people up to Salford to look at how they do the wards there. They're much calmer and they work much better, and we're going to do that here. And, he's a great chief executive. He's got a very ambitious team. He wants his hospital to be one of the best in the world. And he's going out and trying to learn from best practice. And that's, I think, how you do it. So it's creating that hunger for learning and innovation on the front line, that I think is the heart of it.